Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor William Levine from New York City. Dr. William Levine is a Frank Stinchfield Professor and Chairman at the Department of Orthopedic Surgery of the Columbia University College of Physicians and Surgeons, and also the Orthopedic Surgeon-in-Chief of the New York Presbyterian Columbia University Medical Center. Dr. Levine is an internationally renowned shoulder and elbow surgeon. He has been the past president of the American Shoulder and Elbow Society and has dedicated his career to patient care, education, research, and mentorship, sponsorship, and allyship. So today it's my great honor to introduce you to Professor William Levine from New York. Over to you, Professor.
Good morning, Dr. Gopalan and Al-Khatib. It's a pleasure to be with you all today. I'm sitting in my office in New York City, and one of the wonders of Zoom is that we can communicate and educate each other from around the globe. This is one of my favorite topics to talk about because it's an ever-changing field. And so we're going to talk about bone loss and shoulder instability today. And I'm going to give you some controversial topics and thoughts, and I'm going to be purposely provocative because I think that's the way we all learn. Here is my disclosure, none of which should influence this presentation. My three takeaway points for the listeners. Arthroscopic Bankart should only be done in isolation in first-time dislocators. If you're doing it as an isolated procedure in somebody with recurrent instability, you certainly are increasing risk of recurrence and failure. Number two is open Bankart should have a renaissance, and it's sad to see that many young surgeons have never seen this operation. And number three, Latarjet is not the gold standard for instability with bone loss, in my estimation, moving forward in 2025 and beyond. So three cases that I'll start with, and then we'll conclude on what I did in each of these cases. Case one, a 24-year-old with 5 years of traumatic instability, no prior surgery, and has self-reduced dislocations more than 10 times, and has the typical physical exam. Case two is an 18-year-old Division I linebacker, American football, for those of you who don't know what a linebacker is, and had an arthroscopic Bankart and now has had recurrent dislocations following his previously successful surgery. And case three is a 25-year-old right-hand dominant male, had an arthroscopic Bankart in 2015, now has 31% bone loss with recurrent instability. So what would we do for those three cases? And by the end of this talk, hopefully you'll understand why I chose the procedures I chose. So I'm going to go over the history of instability surgery. I'm a student of history, and I always love going back. We'll talk about Bankart and Bankart plus remplissage. We'll talk about bone procedures, and I will leave you with my current algorithm, which will hopefully be helpful to decide how to manage those patients who are in front of you in your office. Remember this, the goals of orthopedic surgery are to do no harm. And typically when we do something in orthopedics, we try to fix what is broken anatomically speaking. That means either a direct repair or a reconstruction. And if we're reconstructing, we either perform an anatomic procedure or a non-anatomic procedure. And we'll talk more about that as we move on. So in the history of surgical options for instability, there are more than 300 procedures that have been described. As we all know in medicine, that typically means we don't have it solved yet. And you can see the list of things here. Now, if we think about the open procedures, we go back to 1923 with Professor Bankart describing the essential lesion of anterior instability and repairing the anterior labrum and IGHL. In 1943, Magnuson and Stack described the transfer of the subscapularis from the lesser tuberosity to the greater tuberosity, with the thought being we would limit external rotation so much that they'd never be able to engage their Hill-Sachs lesion. 1948, Putty and Platt described their imbrication procedure, where we take the subscapularis, we incise it 2.5 centimeters from its insertion. We then maximally internally rotate the humerus, take that external flap and sew it into the inferior glenoid, take the medial flap, and then go pants over vest over the top. So an unbelievably productive or successful procedure with elimination of recurrent instability, but also unbelievably terrible in producing post-capsulorrhaphy arthritis in the very tightest fashion. 1980, Dr. Neer, the father of shoulder surgery from New York Presbyterian and from Columbia, where I sit today, described the open capsular shift procedure. From an arthroscopic perspective, 1980, Johnson describes the earliest technique of a scope Bankart and capsulorrhaphy using staples. 1987, Morgan describes a transosseous suture technique. 1988, Wiley describes a metallic rivet. In 1993, Gene Wolfe from San Francisco uses suture anchors to perform an arthroscopic Bankart. Remember this about bone loss and instability. Even after the first dislocation, we typically have some level of bone loss, up to 22% of people. 76% of patients will have bone loss after a second episode. So if you're not thinking about bone loss in your patients with instability, you're often missing a significant part of their pathology. Let's talk about the bone procedure options historically. We could use the iliac crest and the coracoid are the two most commonly performed. We go back to 1917, where Eden described the first procedure and Hibinet in the same year. They described the tibial cortical graft and then switched to the iliac crest, eventually fixing it with screws. Bristow in 1958 has this procedure named for him, where we take the tip of the coracoid, fix it with one screw. It was actually named, Helfet named it after him, and they were famous for saying, "We treat patients, not the disease." I love that. And Bristow, again, never described this technique himself, but Helfet did it in his honor. Obviously, Michel Latarjet gets the credit for describing the eponymous procedure. He was born in Lyon, France. He described the first technique in 1954. He modified it a bit, but basically it was taking the entirety of the coracoid and fixing it with two screws for better fixation and rotational control. Eden Hibinet decreased in popularity over the decades due to donor site morbidity and increased DJD in long-term studies. And non-anatomic repairs for shoulder instability included the ones I mentioned, as well as the Nicola procedure, a biceps rerouting. And most of these have fallen out of favor, obviously with the exception of the Latarjet, which we will address later. There were really two transformational articles in orthopedics that changed the face of instability surgery. One in 2000 from Steve Burkhardt and Joe DeBeer, and one in 2002 from our colleagues at the West Point Academy in New York, where they described treating first-time dislocations in cadets with surgery rather than treating them non-operatively and waiting for them to recurrently dislocate. So these were two quite transformational or disruptive papers. And the world really turned upside down in 2000 with DeBeer and Burkhardt's article, where they looked at bone loss, instability, and contact athletes. And so in 194 patients with a Bankart repair, 6.5% recurrence with no bone loss, 67% recurrence with bone loss, and 89% recurrence if you had bone loss and you were a contact athlete. Looking at that a little bit more, if you're a contact athlete, 14% failed, but 89% failed with bone defects. So this really paved the way for our understanding of how significant bone loss and shoulder instability really is. And the second article, as I mentioned, is the Arciero Bottani article. Now, what's very interesting about this article is that if you read the article, it was really only 24 patients that were included in this study. It was not randomized, and 14 patients were immobilized and then had supervised PT. 10 patients had an arthroscopic Bankart with a very first generation type procedure, the SureTac, which was a bioabsorbable PGA device that resorbed in about 6 to 10 weeks. The recurrence, however, 75% of the non-operative group, 6 of whom ended up having open Bankarts, and 1 out of 9 or 11% had recurrent dislocation in the operative group. So this basically introduced the proof of concept that perhaps operating on someone after a first-time dislocation could change the natural history from recurrent instability in the plus 70, 75, 80% range, as Hevelius had shown us, to much, much smaller. And it really changed the way we thought about it, first in the military, but then obviously it extrapolated into the civilian population. The problem we have seen, however, is that scope Bankart in contact athletes, as mentioned, has had a very high failure rate, much higher than open instability and certainly Latarjet, et cetera. So this has been the recurring theme for going on 20 years, that arthroscopic Bankart isolated with contact athletes leads to high recurrence rates. Now, what about remplissage? So remplissage has really been addressed significantly in the last decade. And this article from Peter McDonald is a prospective randomized control trial only done in Canada because they do it so beautifully there. But they had 54 athletes who had an arthroscopic Bankart in isolation, 54 who had an arthroscopic Bankart plus remplissage. Recurrence, 18% in the Bankart alone group, 4% in the remplissage group. The risk factors identified for failure were lesions, Hill-Sachs lesions greater than 20 millimeters and or greater than 15% in size. So this is from 2021. Now we have Albert Lin from Pittsburgh doing a multi-center retrospective study, minimum 2-year follow-up. Again, look at the numbers, 127 isolated Bankart, 11% failure rate, 1 out of 56 with remplissage, 1.8%. Risk factors for failure, young age, contact sports, significant glenoid bone loss. We see that recurring themes. But it's important to mention something called spin. And I don't know if you guys have learned and read about spin, but you must understand this. And spin relates to a reporting bias with minimization of negative findings and overemphasis of positive findings. There are 3 broad categories of spin: misleading reporting, inappropriate extrapolation, or misleading interpretation. Why do I bring up spin? Well, because there's a lot of concern about it. And these are the 9 different categories of spin with respect to remplissage, going back to the original article by Yavchits et al. From 2016, where spin was first defined. And a recent article in Arthroscopy of 2024, they looked at 15 systematic reviews and at least 13, 87%, had at least one form of spin. The most prevalent was type 9, meaning the conclusion claims the beneficial effect of experimental treatment despite a reporting bias. So 73% of the systematic reviews had some form of spin or reporting bias to support the positive impacts on remplissage. This doesn't mean remplissage isn't successful or might not be successful, but it does mean we have to make sure we very carefully review the literature. Now, this is not unique to remplissage. If you look at spin in shoulder surgery literature in the last 5 years, 100% of systematic reviews on superior capsular reconstruction had some form of spin, greater than 90% on balloon spacers, greater than 50% on tendon transfers, and about 1/3 on rotator cuff and proximal humerus fractures. So I think it's obvious to say that we have to get a better handle on what this really means and how do we interpret the literature moving forward if there is so much bias that's being reported. And I think that'll be a topic for another discussion on another day. Now let's talk about open Bankart, a procedure that many young residents and fellows and young surgeons have not seen. Mike Pagnani really gets the credit for highlighting the benefits of an open Bankart in contact collision athletes. These were American football players who had a 3% recurrent subluxation rate, 89% return to football. And the literature is replete with a number of studies over the years showing the benefits of open instability surgery and the successful outcomes. What about open Bankart with bone loss? Because we talked about bone loss a lot so far. Well, there's a number of studies from the past that showed that an open Bankart very nicely addresses glenoid bone loss of significant glenoid bone loss with a small recurrence rate by Carter Rowe, 12% with Dr. Biliani, and 3 to 6% by Tom Gill in 1997. This study by Pagnani showed with 14% had glenoid deficiency. That's likely underrepresented, to be perfectly honest. They didn't get CAT scans on those patients back in those days, but only had a 2% recurrent instability rate. So our timeline, if you think about this, is open non-anatomic 1920s, open anatomic Bankart ACLR capsular shift 1980s, arthroscopic Bankart capsular shift 1990s to the present, open Latarjet 1954, arthroscopic Latarjet early 2000s, open distal tibial allograft 2007, scope bone graft 2009 to present. What happened to the open Bankart? It got lost. We kind of forgot that that was an option. And I would encourage you to go to ViewMedi. This is my partner, Dr. Michael Knutson, who did a beautiful video to show you exactly the elegant nature of this procedure. Long-term follow-up shows that these patients do well, and their concern is that they might get degenerative changes, but certainly not a high incidence of doing so. Hill-Sachs management, as we think about, lots of different options, but again, remplissage would be the procedure of choice for most of us in 2024. Critical bone loss is something we talk about, and when we first started defining this, it was greater than 25%, and it's steadily gone down now, and now some people say any bone loss that's unipolar or bipolar could be subcritical and needs to be addressed. So it remains to be seen, but there's a number of studies, and we give J.T. Tokish and many others a lot of credit for introducing these concepts and showing us that at least right now, 13.5% seems to be the number where below which results are better than over 13.5%. Now, why did the Latarjet become the gold standard? It was a great operation. We had an influential early user and one of the most famous shoulder surgeons of all time, Gilles Walsh, and it gets propagated at national, international meetings, which can be good and it can be bad, because if you have somebody like Professor Walsh, who's an expert surgeon and reports a 2% complication rate over 3,000 cases, very influential. But the question is, does the rest of humanity, can the rest of humanity replicate Professor Walsh's excellent results? And we look at the innovation cycle, and this is what all of us as surgeons have to decide, is where are you going to be? Are you going to be on the innovator side, where you're actually introducing new technology, new techniques? Are you going to be on the laggard side, where you're a skeptic? Or are you going to be someone in between who kind of sees where things are, and then you wait and watch? And it's always important to recognize this when we see new techniques like superior capsular reconstruction have a very short innovation cycle and now falling off the map altogether because the results didn't seem to match the enthusiasm with which it was being performed. So the Latarjet, I would say to you, is the gold standard for patients with shoulder instability and bone loss. It was a procedure of choice in France and others. In North America, we considered it more of a salvage operation, revision situation, severe bone loss in primaries, maybe 30% or so, but not the procedure of choice for first-time dislocators for sure. How does it work? Well, it's the triple blocking effect. What is that? It's a bone block, expand the Gulf T, the sling effect of the conjoint tendon, and the capsular repair. And how does it, the triple blocking effect is what we've all been taught, and that is the sling effect, capsular repair, and bone block. And so is that really real? Well, a recent study looked at it and showed actually no difference doing a capsular repair without a capsular repair. So that part of the triple blocking effect is questioned. And then even the sling effect, some have said, yes, it's important, and some have said no. So it's not entirely clear that that's exactly how it works. But one thing is for sure, arthroscopic Bankart and Latarjet are the two most rapidly increasing operations performed for instability over the last 2 decades. This paper from Hasker in 2022 shows those two findings. What about scope versus open Latarjet with respect to complications? 16% complications, reoperation rate of 2.6%. If you look at systematic review of scope Bankart, open Bankart, and open Latarjet from 2022, we find that the scope Bankart is a faster operation, less serious adverse events, and decreased reoperation rate. The Latarjet had increased serious adverse events, increased reoperation, increased deep wound infections, and so we saw in the same period of time increased scope Bankart and decreased open Bankart from 16.6% down to 8.8%. A study just for this year looking at arthroscopic Bankart versus Latarjet 13,000 shoulders. Arthroscopic Bankart had a 3-time higher rate of recurrent instability, 47% decreased complications, and a slightly slower return to sport than Latarjet, but really only about 2 weeks or so. This is really the concern that many of us have, the complications that aren't reported by others, 25%, 30%, 10%, 13%. And some of those are minor complications, but many are not. And so this study from 2023 showed 1.9%, 48 patients out of 2,500 had nerve injuries. That's not insignificant because obviously almost nobody ever gets a nerve injury in an arthroscopic or open Bankart. Post-op non-unions and instability do occur in Latarjet, so it's important to recognize that it's not fail-safe even when you don't get a more serious neurologic complication. So bent screws have been seen by all of us. So here are my 4 main objections to the Latarjet. Number 1, it's non-anatomic. Number 2, the labrum is resected. Number 3, complications are not benign if they occur, similar to arthroscopic or open Bankart. And number 4, and this is really important, it fails my what next mantra in surgery. As a surgeon, we all should be asking, what do I do if this operation fails? What is my next step for this patient? If the patient requires an arthroplasty, significant risk of nerve injury, and significant altered normal anatomy, Joaquin Sanchez-Sotelo and our friends at the Mayo Clinic have shown a 30% revision rate in patients with failed Latarjet who get post-capsulorrhaphy arthritis and require reverse total shoulder arthroplasty. Just take that in for a second. 30% revision for patients who have post-traumatic arthritis after a Latarjet and need to have a reverse total shoulder placement. I mean, that is really, really concerning data that I think we need to pay close attention to. So there really wasn't much new in instability surgery for about 5 decades until a guy named John Sakaya, a wonderful surgeon in Michigan, who popularized arthroscopic allograft glenoid in 2011. So what other options do we have? We have distal clavicle autograft, we have iliac crest autograft, and then the DTA or distal tibial allograft. The distal clavicle autograft has been popularized by J.T. Tokish and Oke Anakwenze, as well as Pascal Boileau. And it's an open harvest of the distal clavicle. You can fix it with sutures, suture anchors, or even a screw. The pros are it's an autograft. It's locally available. It may or may not have cartilage. I don't think that's really advantageous. But a significant con, as George Athwal showed us, is that you can really only make up for about a 22% bone defect with this technique. And so that's a concern. Bone density is a concern. Sometimes the lateral clavicle doesn't really have the best bone density. And of course, osteoarthritis is very common of the AC joint. So I don't think that's a huge issue. I think the other 2 issues are more concerning. The literature review is small, but there are some reasonable studies, and we've seen here, and Pascal Boileau has, as I said, has used the congruent arc with 2 buttons. Oke Anakwenze has a nice LinkedIn video on this with 4 buttons, and so it's something to consider with people who have smaller bone loss, less than 22%. Revision iliac crest is again an option. 46 patients, 80% satisfactory is in one study. About 11% recurrent instability, 5% revisions. This really was popularized by Herbert Resch from Austria, and he described the use of the J bone graft and actually crafted it in such a way that he didn't even require any hardware, which you can imagine is a technical feat. And so he press fit this in most of them and only used 3 screws and showed pretty good results with this operation. Marcus Scheibel has then converted this to an arthroscopic procedure and reported in 2021 a small series with reasonable results. Primary iliac crest was reported earlier this year in 32 patients. 100% had graft healing, no recurrence. This is a very short-term follow-up study, so we obviously need much more information and follow-up over time. The distal tibial allograft is really the new kid on the block that's most exciting from my standpoint, but it's not that new. Actually, go back to 2009 when Matt Preventure started to work with Tony Romeo. They were applying for grants with John Sakaya. but they really couldn't get the glenoids. They were very hard to get because of open caskets with 4/4 amputations. And Ralph Diaz, who worked for JRF, said, "Hey, doc, would you have any use for the distal tibia?" They tested it in the lab for 1.5 years. Here you see the famous video given to me by Matt and Tony that shows the incredible congruence of the distal tibia with the humeral head. So the rationale for the DTA is the geometry fits. There's no limits on size, unlike the coracoid or the distal clavicle. You can make it anatomic. It does have articular cartilage if we think that's important. Availability is a concern, obviously, outside the US, but getting fresh frozen and fresh grafts is probably not necessary. And I think you can probably use frozen grafts as Ivan Wong has shown us from Halifax. So the first series was just a kind of proof of concept that Matt and Tony wrote about in 2009, 3 patients with severe bone loss, and showed that this was a reasonable technique. They then followed up their series with 27 patients with about a 4-year follow-up, showed no recurrent instability, allograft healing in 89%, and only one complication, which was an infection treated with revision DTA. Ivan Wong from Halifax took the same concepts and said, well, how can we do this arthroscopically? And has been on a journey for the last 9 years to teach the rest of the world how to do this safely and reproducibly. He's shown that this is a good operation. Again, 67 patients, 100% graft union. They do get resorption of some of that bone graft. He calls it remodeling, and usually that's what it does. And so you'll see that not infrequently. A number of other authors have also reported reasonable early results, but of course, we still don't have any long-term results because of the relative newness of this operation. So let's go back to my 3 cases that I started this talk about today and see what we did. Case 1 is a 24-year-old male, 5-year history of traumatic instability, no prior surgery, and has self-reduced more than 10 times, has an exam consistent with instability, but no ligamentous laxity, and has normal strength. Here's his coronal MRI on the left, showing an intact rotator cuff, of course, and labral pathology. Here's the axial images showing anterior labral pathology. So what did I do in this particular case? Well, here's the anterosuperior view showing my separation of the capsulolabral tissue. This is just an example of making sure that you have the right trajectory. Sometimes things don't go according to plan. You can see my trajectory was a little too steep with that drill guide, and that anchor pulled right out. So every once in a while, you have to so-called MacGyver things, and we can put it in from a different portal and pass from our posterior portal here, as I'm showing in this particular case. We move up to the 5 o'clock anchor, and we're using a knotless system and technique for this particular repair. I've gone to the knotless anchors for the majority of these cases. We're coming below the level of the anchor so that we can get what we like to think of as a south to north advancement of the capsulolabral tissue, and that we are always thinking about south to north shift, not east to west shift. I'm not purposely trying to limit rotation. I'm trying to reduce the capsular redundancy that occurs in most patients who have recurrent instability, as shown a long time ago by Roger Pollack and colleagues here at Columbia. And so the way I use this technology is that we put one anchor in, we tighten and tension it, and then we don't cut the first one. We hold that one, then put the second one in, and then cut the one below. And that is because there can be a little bit of creep in these sutures and anchors, and so I like to retension them before we definitively cut them. Then we move up to the 3 o'clock position, and we continue up the clock face to anatomically restore the entire capsulolabral complex. Then we move to the remplissage. You can see here, we're taking a shaver so we can decorticate the bone of the Hill-Sachs lesion. We use 2 knotless suture anchors placed into the Hill-Sachs, one anterior and one posterior. And then we're going to take those sutures on the extracapsular side. You don't need to go into the subacromial space with this technique. It's quite elegant. And then we take one suture from one anchor, put it into the loop of the second anchor, and then simply do a knotless remplissage into the Hill-Sachs defect, as we said, is most important if we're doing an arthroscopic Bankart. And so now we've passed the sutures through the opposite anchor, and we're then going to properly tension them. 1 year post-op, back to all sports and activities, no recurrence, and has full range of motion without loss of internal rotation. Case 2 was our Division I American football player who failed a prior arthroscopic Bankart. He has a recurrent labral tear and a small postage stamp fracture with measurement of bone loss of about 16%. Very interesting because we had lots of discussion. This is a Columbia student athlete who was a very bright young man. And he actually did a lot of research and came back to me and said, well, why don't you do an open Bankart, since that's an operation that's done so well over time? So that's exactly what I did. Here's the first important technical part, and that is separating the subscapularis from the capsule and trying to then take the, you can see we're now mobilizing the subscapularis. Now this is another technical pearl. We now have the capsule, and I use the 90-degree suture lasso to very precisely pass our sutures from the glenoid into the capsule labral complex right at the glenoid margin, so that we're not over lateralizing our sutures and potentially, again, shortening the capsule in an east-west direction. We're putting these in vertical mattress fashion. I use doubly loaded suture anchors, so I use 2 anchors with 4 suture pairs placed in vertical mattress fashion. And then we're going to anatomically repair the capsule with a slight superolateral shift. You can use anchors on the humerus if you have soft tissue loss, and then an anatomic subscap repair. You see we use those white sutures at the top of the subscap to make sure we could anatomically reposition the subscap in proper position. And we do a figure of 8 closure with a number of tendon to tendon sutures so that it's a beautiful repair of the subscap. Returned for his senior year of football. He actually was named all-conference and team captain and had no further instability. So the open Bankart is still a wonderful operation. Take-home points of this case: Pagnani, again, gold standard for contact athletes, never has been replicated by any arthroscopic instability literature. Let me restate that. No arthroscopic instability paper has ever replicated the results of Dr. Pagnani. Do not throw away the open Bankart. It's a great operation, and I hope this next generation of surgeons can learn how to do this operation, because I think it's a beautiful option for many of our patients. Case 3, the 25-year-old male with 31% bone loss. This is going to be the arthroscopic distal tibial allograft, and these are my keys to doing this case well. So patient position, we're going to be in the lateral decubitus position. Portal placement, we're going to have antero-superior, antero-inferior, posterior, and then I'm not sure if the arrow is showing up, but the Halifax portal is going to be the portal to deliver the graft in the case. So graft preparation on the back table, there's some commercially available devices. You can do this freehand. Usually I make a 20 by 15 by 10 millimeter graft, depending upon the bone defect, but that's our kind of our go-to. And then you have a system where we put the top hats into the bone graft, and then that allows us to connect the delivery gun directly to the bone graft, so that helps us to position the graft intraoperatively, and is a reproducible way to do this. So glenoid preparation is going to be quite different than our typical arthroscopic instability. Here you can see that the tissue is healed medially, and so we have to mobilize that significantly. I start with the hook cautery and then go to the standard cautery. And then we're going to put a traction suture in. So we're going to do a luggage tag type suture. I'm looking from antero-superior. We put our luggage tag in, and that suture is going to be used later for our capsule labral repair. We're going to do a significant interval resection, so the entire rotator interval needs to be released. I'm now looking from posterior, and we have to release everything so that we can get our graft in. So our landmarks are going to be, the key is going to be the subscapularis and the strap muscles of the coracoid. We need to be superior to the subscap and lateral to the coracoid, of course, to avoid neurovascular problems. We are now taking a switching stick from the posterior portal. I'm looking now outside, as you can see, and we brought the switching stick in to the Halifax portal, created a 3 centimeter incision, and now we're dilating. We've taken the dilate. We're now taking the dilators, and this is to make sure two things: one, that we have enough space to get our graft in, and two, that we can displace the subscapularis to the 6 o'clock position. If you cannot displace the subscap to the 6 o'clock position, you have not done enough releases. There's likely contracture of the coracohumeral and the anterosuperior capsule, and that has to be released. Now we're viewing from posterior. We're bringing our graft in from the Halifax portal. We're going to then switch back to the anterosuperior viewing portal. We're going to look directly on FOSS and see our distal tibial allograft. We have a switching stick in coming from the posterior viewing portal, and that's going to be displacing that subscap inferiorly. We're then going to pass wires from anterior to posterior, shown here on the external view. And this is going through the delivery device and through the two top hats. So these are going to be our cannulated screws. Now we're going to pass our screws or place our screws. Usually they're 34 to 36 millimeters. We're looking at all times at making sure we like our trajectory of the screws, that we like the graft placement in the inferior quadrant. And then we can go to doing our labor repair. And here we typically use a knotless anchor system. You can use 1 or 2 anchors depending upon the capsulolabral tissue, and bring that back. And I do bring it over the graft so that we have a belt end suspenders, we have bony augmentation, and we have the benefit of the labral capsule reconstruction. Here's his final x-rays showing a beautiful graft incorporation, and here's the outcome 1 year post-operatively. He has no pain, no instability, and he's returned to all sports, and you can see his outstanding range of motion. So my algorithm in 2024 for treatment of shoulder instability with bone loss: if you have less than 13.5% bone loss and an on-track Hill-Sachs lesion, that's going to get an arthroscopic Bankart plus remplissage in my hands, or an open Bankart. If you have less than 13.5% and an off-track lesion, you're going to get the exact same, either remplissage, arthroscopic Bankart, or an open Bankart. If you have around 15% or more bone loss, then you're getting into the area of concern, and I'm likely going to do something on the bone side. And for me today in 2024, that would be an arthroscopic distotibial allograft. I've done just over 75, I believe, at this point. I've had 2 failures in 2-year follow-up, and so far I'm very happy with the outcome and the results. So, summary: non-anatomic procedures were done because there were no other better alternatives. Maybe they're good, but not great. Arthroscopic Bankart is definitely not great by itself. Plus remplissage, I think, is certainly changed the playing field. But as I mentioned, we have to be careful and critical about reviewing the literature. I believe the open Bankart should have a renaissance. And despite the Latarjet being a beautifully elegant operation, I no longer perform it. And I perform an arthroscopic distotibial allograft because it avoids the subscapularis. It's more anatomic, but of course we have to have longer term follow-up studies to be confident. My 3 takeaway points, Professor: as I mentioned at the beginning of this presentation, arthroscopic Bankart should only be done in isolation for first-time dislocators. Otherwise, you should be either doing a remplissage or another operation. The open Bankart should have a renaissance, and the Latarjet is not the gold standard for instability with bone loss, in my estimation. Thanks very much for your attention.
Thank you very much, Prof, for this wonderful presentation. Prof, you can stop sharing. Great. Thank you, Prof, for this spectacular talk. You've covered the entire spectrum, the entire gamut of instability surgery. Prof, couple of questions. Prof, a few years ago, we used to talk a lot about Prof. Matson's group, the Tubbs and the Embry group, right? The multidirectional instability. So how do you treat the Embry group, the multidirectional? Suppose I'm not talking about habitual dislocation, but the other group.
Yeah, I think if someone truly has multi-directional instability with generalized ligamentous laxity, increased Baton scores, they can take their arms and turn them 180 degrees. Those are the patients that, I don't care what operation we're talking about that we just reviewed, they're likely to fail. And so we definitely want to try to avoid surgery at all costs in those patients. They go through extensive rehabilitation and physical therapy. If there is a component of volunteerism or voluntary instability, then trying to get psychological help for them is important. But I will say it's been extraordinarily disappointing. I don't think we have a solution for certainly for the psychological side of it. And the MDI patients in general, I think you have to be careful of. I've heard patients or surgeons from Europe tell me that they do a Latarjet on people with MDI and then they continually dislocate. And of course, it's not a bone procedure, a bone problem to start with for the most part. Those patients rarely have bone loss. They just have profound collagen problems. So unfortunately, we don't have a great solution. My usual answer is try not to operate.
Thank you very much, Prof. And Prof, what is your take on this relatively new surgery, dynamic anterior stabilization, popular in Europe? I'm sure you've seen surgeons like Alexander Lederman, Clara Campos traveling to Shoulder 360 to talk about DAS for shoulder instability.
Well, I don't know enough about it yet. And I don't, so again, with new procedures comes new enthusiasm and then usually waning enthusiasm once we see longer term results. So I will be happy to see what Professor Lederman shows us with 5-year follow-up data so that we can know if it's an operation that has a durable, lifespan for us.
And Prof, you mentioned about arthroscopic lethargy, right? So what has been the trend in the US? Are surgeons moving to arthroscopic lethargy? Because I've seen a lot of surgeons in Europe. I've hosted surgeon from Norway. I'm sure you know her. Bertie Bo is a very popular surgeon who has shifted to arthroscopic lethargy. And a lot of surgeons from this part of the continent, they moved to France to learn from at Nice on arthroscopic lethargy. Do you think the trend is moving to an arthroscopic lethargy? And you mentioned about a 30% revision risk with an open lethargy, right? In case they do a shoulder arthroplasty. Do you think it could come down with the arthroscopic lethargy?
Well, there isn't any evidence that the arthroscopic Latarjet has decreased complications that I'm aware of compared to open Latarjet. We'll have to see. The study I did showed equal complications rates in both. I would say the trend in the US has not been to go to arthroscopic Latarjet. And even many of the expert shoulder surgeons in the world who perform Latarjet as their go-to do so open still to this day and are not believers or converts to the arthroscopic version of it. And I think that goes to show that, if you think about other examples, whether it's Bankart or rotator cuff repair or ACL reconstruction, there's almost a universal shift to the arthroscopic version once the technical kind of nuances are overcome. That has not happened with Latarjet. So that would suggest to me that the Latarjet, the arthroscopic Latarjet, remains a singularly difficult technical obstacle to overcome, and that most surgeons, I would say, have decided in their own hands they're better off sticking with what works for them, which is an open Latarjet. And again, for experienced surgeons who do the open Latarjet, I'm sure those complication rates are lower than what I've reported here today, but they're not zero. And if you talk to experienced shoulder surgeons and ask them if they have a muscocutaneous nerve palsy or an axillary nerve palsy or significant hardware complications or on, they'll all say yes. We've all either seen it or treated it or had it. So, but it is safe to say that people who do more of any operation are going to have less complications than those who do less. And that gets to the whole issue here. We've told a generation of shoulder surgeons and orthopedic surgeons that they should be doing a Latarjet. And so you're telling someone who might be doing 10 instability operations a year that they should be doing an operation which in their hands might lead to serious complications. So wouldn't that surgeon be better off doing an open Bankart if they knew how to do it well, which has had a long track record of success and great outcomes. That's my point to people. It's not, obviously I'm being provocative by saying I don't do Latarjets. The Latarjet is a great operation. It's not going anywhere. And in many people's hands and many surgeons' hands, they'll probably continue to do it. But what I'm pointing out is that we forgot that whole middle group, the open Bankart group, and we forgot it because we pushed it. The community pushed Latarjet because the arthroscopic Bankart was failing so miserably, and we said, "Oh, it's a bone problem. Let's go to the Latarjet."
Thank you, Prof. Prof, we also joined by Loiy. Loiy Al-Khatib is an orthopedic sports surgeon. I'm sure you know him very well. He's practicing in Dubai. Loiy, welcome to the show and your questions to Professor Levine.
Thanks, Professor Levine, for the wonderful talk. This is the most wonderful talk that I've ever seen, covering almost all the aspects in shoulder instability and bone loss. One question about open Bankart. Nobody is talking about it. And do you think there's still a place for this open Bankart repair? And would you agree that open Bankart repair would give you the same results as arthroscopic Latarjet? Because I couldn't find any review comparing both techniques together, comparing them together.
There isn't a review because open Bankart has fallen off the face of the map in large part. But I agree with you. I think that the open Bankart, if you talk to surgeons, I was just on a panel with Dr. Arciero at the Somos Military Academy meeting, and we were talking about open Bankart. Dean Taylor from Duke was talking about it. Samuel Artuna from Spain was talking about it. So there's a number of surgeons who have gray hair, mostly, or no hair, who believe strongly that it will have a renaissance, but it will only have a renaissance if we do a better job of communicating to the younger surgeons that this is an operation that they should be considering doing. So tomorrow I have 10 surgeries in my OR, and one of them is a young man who had a failed arthroscopic Bankart, has no bone loss on the glenoid side, has a small humeral detachment, a small Hagel lesion as probably a major source of his instability, but he's getting an open Bankart and capsular shift. It's very easy to take care of both the labral pathology and the capsular pathology with an open procedure. It's actually more challenging to do a Hagel arthroscopically. As you know, that's kind of again, a high risk type operation. So open instability surgery is being seen and done by my residents and fellows, but admittedly not as much as I think it should be. So I'm trying to participate in walking the walk and talking the talk, and having my residents and fellows learn this beautiful operation.
Thanks a lot, Dr. Levine. I think that was my question, and hope to meet you again.
And Prof, also, in case someone is going for an arthroscopic surgery, and due to some reason, if he cannot pursue, he should be a master of open, right? So open should be like, before you move to arthroscopy, you need to be a master of open surgery, isn't it?
Well, if the question is what happens if you can't do it arthroscopically, yeah. Sure, that's always an issue. And what's your backup plan? That gets to my what next mantra. If I can't do the arthroscopic Latarjet, I have to be able to open and do an open Latarjet. If I can't do a arthroscopic Bankart, do I know how to do an open Bankart, or what is my backup plan? And as surgeons, we always hopefully have a backup plan.
Thank you very much, Professor, for those final remarks. We need to have a backup plan. Thank you, Prof. I think that's all the questions that we have for this session. Thank you for this wonderful talk, and really look forward for more in the future.
Thank you very much for having me. Have a great day, guys.
Thank you so much.